From the American Neurological Association, I'm Adeline Goss. This is ANA Investigates. Football fans may remember in January 2023 when Damar Hamlin, a player for the Buffalo Bills, suffered a cardiac arrest and collapsed on the field during a game on live television. He had a remarkable neurologic recovery, prompting us to focus our podcast that month on the need to avoid nihilism when we prognosticate after cardiac arrest. But what is the right balance between pessimism and optimism? Today we'll hear from Dr. Karen Hirsch, neurointensivist and associate professor of neurology at Stanford, about finding the Goldilocks zone in neuroprognostication after cardiac arrest. Dr. Hirsch was interviewed by Dr. Sara Stern-Nezer, vascular neurologist and neurointensivist at UC Irvine. Here's Sara.
Welcome, Dr. Hirsch. It's such a pleasure to have you here today to talk about this important topic of how we look at treatment and neuroprognostication after cardiac arrest and the new tools on the horizon to help with this important clinical topic.
Thank you so much for having me.
It's a pleasure. I know we talk about neuroprognostication after cardiac arrest so much. It's a huge topic. It's such an important topic. And I think both of us as neurointensivists have that experience of being at the bedside and having to answer really hard questions for patients. This is something that we've covered before on ANA Investigates, mostly focused on like Damar Hamlin and a lot of the work around that and the Curing Coma campaign, which I know you're very active in. Most of the time, I think we're talking about avoiding nihilism and prognostication, but there is some newer literature that suggests we may have swung too far away from that, and now we risk overly optimistic prognostication. I know Dr. Elmer has a paper in 2020 that talks a little bit about this. Where do you think we are right now on this tightrope between self-fulfilling prophecy and nihilism and over-optimism?
Yeah, it's a great question and I think an important point, and I will answer it. But before I do, I think I'll take a little bit of a step back and just say, I think philosophically, we have to ask ourselves what we are doing when we try to do neuroprognostication. I think that my thinking about this has evolved over the course of my career. With age comes wisdom, or perhaps just changes in thinking. But I think our goal overall is to paint a reasonable picture for family members and surrogates. And at some point, hopefully there's enough recovery for patients as well about what a realistic future looks like. And that can mean a lot of very different things to very different people. I think the Curing Coma campaign and the Damar Hamlin case and many others have brought a lot of attention to this concept of neurologic recovery after cardiac arrest. But when we think about what we're trying to do when we prognosticate, it's a really sort of philosophical question, right? I think the first thing is we're trying to give guidance about what long-term looks like, first of all. But second of all, we're also trying to determine just in the hospital setting, who's a candidate for what therapies, what sort of interventions are needed, how do we titrate care to these patients? All of that is sort of fundamentally tied into prognostication. And so to get back to what you were asking in the first place, yeah, of course, I think historically, we know now, looking back, and even in this day and age from current literature, there's a lot of what we would call inappropriate prognostication for poor outcome. And when I say inappropriate, I mean patients who potentially could go on to have a good outcome are being rendered with a poor prognosis. And so that, again, to your point, creates nihilism and withdrawal of life-sustaining therapies and self-fulfilling prophecies of poor outcome. Counterpoint to that, exactly what you said, is we also need to acknowledge as a physician, as a health system, as a society, that there are patients who have devastating injury. And sometimes that is unfortunately very evident within many, short order, within hours of hospital admission, or it becomes evident over time when the person remains critically ill. And we also have an ethical duty to make sure that we are giving a reasonable picture to family members and surrogates of what the prognosis looks like, and also making sure that we're applying advanced therapeutics in an appropriate way to patients who are going to benefit from those. So I would say as a whole, I think that prognostication is still incredibly heterogeneous. I think we probably still have places, and not just places, but individual cases where prognostication is inappropriately negative. I think we also have cases where it's probably inappropriately positive. I will just share, from my own experience, I think eCPR and advanced therapeutics for resuscitation are super exciting and super important. And the pendulum is perhaps swinging too far, where we're offering these advanced resuscitation options to everyone, or not everyone, but people where there is no reasonable good outcome for that person. And so we definitely need to get this right. But how we do that obviously is challenging, and where individual hospitals and practitioners fall on this spectrum is challenging and probably changes day to day and based on the individual patients too.
Yeah, it's something I always worry about too, is that if we're too inclusive in who we're testing these therapeutics on, are we really missing people who could benefit a lot from it? I think I talk a lot with my residents and fellows in the discussion of TTM, which we can get to in a second. We don't look at what effect that has on more subtle neuropsychiatric outcomes, cognitive outcomes, which are things that people do care about, not just MRS. And so have we missed a group that would really benefit in wanting to be as inclusive as possible, which is always a really hard thing in trial design. And obviously also we want to be consistent with repeating studies to look for veracity. But I think that selection is always very challenging.
Yeah, absolutely. I think you really sort of hit the nail on the head on the challenges with doing cardiac arrest research. I think, first of all, cardiac arrest is a heterogeneous disease, but we lump it all together as cardiac arrest. And there's very different phenotypes of what cardiac arrest is. Just like we would say, we don't treat all breast cancer the same, and we don't treat all stroke the same. It seems almost silly that we're trying to treat all cardiac arrest the same, but we are. But the counterpoint to that, of course, is we need large randomized trials to generate evidence. And in order to do large randomized trials, we need outcome scales, and we need dichotomized outcome scales to lump people into good and poor outcome. But exactly like you said, I think we need to make sure we're including the right patients, applying the right therapies to the patients most likely to benefit, and then evaluating outcome in a meaningful way that is not just a modified Rankin scale or a dichotomized outcome scale, but also looking at these more subtle or not so subtle neurocognitive changes and neuropsychiatric outcomes. So I think the field is doing better. Most clinical trials are powering their studies for a dichotomized outcome, but then also collecting long-term data, neuropsychiatric data, neurocognitive outcomes, and publishing that and looking at that, which is very helpful and important.
Absolutely. And that actually segues well into talking about what we are currently using. I know I saw you had a review with Sindroni et al. From 2022 in intensive care medicine, where you looked at a lot of the biomarkers, electrophysiologic studies, examination of different interventions. And there's such variability in the sensitivity and specificity that you see across studies. And I know, obviously, we've moved a lot towards using multiple different markers. But we end up having a huge range of possible outcomes to families. What tools do you think we really need to help have a more narrow prognostic range for individual patients? And what type of paradigm shift do you think might be helpful to get there?
I wish I had a good answer for saying what is going to be the magic tool that is going to really narrow the range on prognostication. But I think a couple of things I would say. First of all, we have to take the whole contextual patient. So I think as neurointensivists, we tend to be good about thinking about how the brain and neurologic injury fits in with the other systemic comorbidities. But that is really not often included in neuroprognostication. We don't want to be ageist. We don't want to be discriminatory based on certain factors. But at the same time, we know neurologic prognosis depends on so many other things systemically that are going on. So I think that's the first thing I would say. The second thing I would say, which is no criticism to anyone, including me and my colleagues who published this literature, but the literature around neuroprognostication is really flawed. And it's just flawed because it has a lot of intrinsic biases in it. Oftentimes, care teams are not blinded. There's a lot of withdrawal of life-sustaining therapy and other methodological issues that basically mean that the literature that we have to work with is intrinsically biased. But all of that said, we do the best with what we have. And certainly, like you said, we want to use multimodal prognostic factors. So certainly EEG, I think, is becoming more and more recognized as a helpful prognostic tool, not just something to screen for seizures post-arrest, but to really be used and looking at background and reactivity. And I think we're going to see more and more EEG work. Imaging, serum biomarkers, all of this is being refined and worked on. The biggest or sort of holy grail of all of this is really understanding functionally what's going on in the brain, especially when people are comatose, and what is that capacity for recovery. So looking at connectivity with EEG or fMRI or other future tools that are going to be developed to really evaluate the integrity of neurocircuits and whether or not the potential for recovery is there. But we have a long way to go. And I think we do the best with what we have.
Yeah, it's always hard. I used to be jealous of friends who worked in a lab because those rats are all genetically identical and they always show up for their follow-up. But no offense to our wonderful basic science colleagues, but it ends up the implementation can be quite challenging. You talked a little bit about tools that we have, tools that we'll develop. How close do you think we are to developing more of these high-level functional tools?
I think close and far. I think that science and technology is evolving so rapidly, and these sort of cutting edge technologies to look at functional connectivity, this high resolution EEG for connectivity, invasive monitoring, depth electrodes, all sorts of really advanced stuff that people are doing is exciting. And the field is just rapidly progressing. Counterpoint to that, though, is that these tools are available at very few select places. If we take a holistic look at cardiac arrest survivors across the country and across the world, the vast majority of these patients don't even get a structural MRI. The vast majority of these patients probably realistically aren't even getting, and if they are, it's not long-term monitoring like you or I would be used to in a tertiary, quaternary ICU level setting. So I think the science and the technology is going to continue on its exponential growth pace, and we're going to have continued understanding of brain function, covert consciousness, what is the sort of go, no-go structural integrity needed for consciousness. So I think all that is at our fingertips, but really deploying this broadly and equitably to cardiac arrest survivors is going to be a very big challenge.
Yes, but as I often say to myself and everyone around me, nothing worthwhile is easy. So
yes,
there you go.
For sure.
We talked a little bit about TTM, which I know obviously has one of the things that's gotten the most attention. I think if you talk to anyone outside of neuro or even cardiology about cardiac arrest, it's the thing that always makes headlines too, right? Or a couple of years ago, the woman who had prolonged arrest, who was in a freezing river, and it's always the front page. And so I think hypothermia has really captivated people both in medicine and outside. Obviously, new data, many places have moved away from more aggressive hypothermia protocols that we had when I was a resident. Where do you see the role currently for hypothermia after cardiac arrest or TTM? And what do you think we need to better understand if it still has a role for certain subgroups?
Sure. I will tell you, of course, what I think, but I'm not willing to be, sort of pedantic about this and say, oh, there's only one way forward. I will certainly acknowledge the literature has made it very challenging. I mean, the literature is what it is, but it has made it challenging to know what the right thing to do is. I think physiologically, from basic science and animal data and other patient populations, such as cardiopulmonary bypass and neonatal hypoxic ischemic injury, we know that temperature control to a hypothermic target or hypothermic TTM is, neuroprotective. However, the literature that we have at our fingertips currently today has really called into the question exactly what you said of whether or not this broad application of hypothermic TTM to cardiac arrest survivors really makes a meaningful difference across the board in outcomes. I think you see some variability regionally. The European guidelines have largely recommended away from hypothermia. The American Heart Association guidelines are still a little bit more broad and their temperature range that they are recommending or allowing for. And I think, that's just reflective of the fact that we really don't see a significant difference in outcomes in the studies, but to your point, don't know still if there's potential subpopulations that could benefit or if we just, had problems with the trials that we did. Counterpoint to that, I was just talking to our pediatric ICU colleagues this week in conference. At some point, you can't just keep denying the literature. You can't just keep saying it makes physiologic sense, but all the trials don't show a benefit. So at some point, we're going to have to sort of answer this once and for all, but I don't know when any of us will feel comfortable that it's been answered once and for all.
I don't know if you know the Thomas Bleck article from BMJ in 1999, where he talks about 7 alternatives to evidence-based medicine. For those of you listening who haven't, it's a hilarious paper, and he's done amazing research separate from this, but I think he has joked that it's his most quoted paper. But yeah, I always think this is a class 0 thing for me, where it's a thing I believe. I totally understand the literature, but I often tell my fellows that if it's me, can you please make me 33 degrees?
I agree. I have told my fellows the same. Please cool me if I come in with a cardiac arrest. I think exactly like what we were discussing earlier, it's a big challenge. In order to really get the answer to this, we need a huge, huge study that is going to have lots and lots of data about phenotypes and individual patients and really, not dichotomized from shockable to non-shockable rhythm, but really understand who these patients are and if anyone is going to benefit, who is going to benefit. I think that some of the work we're doing with our Precise Cap study is trying to get at this, and we can talk about that more. But, we're sort of at the mercy too of enrollment and outcomes and all the other challenges that come with doing clinical research in a clinical trial setting.
I'm smiling because you actually referenced that, which was my next question to ask you. So let's talk about Precise Cap, the precision care in cardiac arrest, influence of cooling, duration, and efficacy in cardiac arrest patient study that you're currently working on now. Tell us more about that, about what you're doing and what you're hoping to gain and the questions you're hoping to answer.
Yeah, so Precise Cap is a NIH-funded study that is a sub-study to the ICE-CAP trial. The ICE-CAP trial is randomizing comatose cardiac arrest survivors to different durations of hypothermic temperature control. And along with my colleagues, Dr. Elmer at University of Pittsburgh, Dr. G. Caden at Hopkins, and Dr. May at Maine Medical, we were, many years ago, having a very similar conversation to this, which was, it seems preposterous to us that we treat all cardiac arrest patients the same. There was so much excitement right back in 2016, 2017, where we were suddenly identifying perfusion-diffusion mismatch and target profiles and really selecting patients for stroke therapy and having these amazing outcomes. And so sort of in parallel to that with my colleagues, we are saying, how is it that we don't have good biomarkers for patient selection for cardiac arrest trials? And how is it that we're so far behind in this field in identifying patients who are likely to benefit and really developing therapies tailored to those patients? So the fundamental premise of Precise Cap is that all cardiac arrest patients are not created equal, and that potentially with high resolution multimodal data collection, both of EEG, cardiopulmonary waveforms to get at the systemic injury, and then imaging, we could start to create these multimodal biomarker signatures of patients who are going to respond to different durations of hypothermia, and then also be able to have signatures for long-term outcome. And so we have 13 sites that are participating around the country. It has been an excellent learning experience, and we're super grateful for everyone that has contributed to the study. And we have over 100 enrollments at this point and are certainly chugging along. Some lessons learned without divulging anything I'm not allowed to divulge about the study are that, it's very challenging to get this much high resolution data. So anytime people talk about doing big data in medicine, and like the biggest data is the continuous monitoring and the labs and the medications and like all the things we do in the ICU. So it's been a huge informatics ask and really data management sort of learning curve to make sure we're capturing all of this important data. The other thing I would say is just getting this on critically ill patients. Just like you said, in the real world, what's sort of actually happening and what we think happens when we're like taking a step back as investigators versus what's actually happening in the ICU is often very different. So we have huge gaps in data. We have huge amounts of missing data. We're just trying to put it all together in a way that's meaningful and that will allow us to draw some conclusions from it. But I'm despite all that, optimistic that we're going to get a lot of important information out of this.
When I talk to patients and I explain why I'm involved in this issue of cognitive outcomes, the questions I get are always just so hard to answer because often the questions are about intellect, memory, personality. What types of outcomes are you looking at now to help answer those questions? We talked a little bit about the limitations of modified Rankin scale, although it does have statistical power. But what types of outcomes are you looking at now, and what are the other outcome measures you think we should be looking at for more patient-centered outcomes in cardiac arrest?
Yeah, a couple of things. I think, we know that patients and family members want to have accurate prognostication about a range of outcomes. A lot of times that means different things to different people. And so I think we have to tailor it to what people want to know, first of all. But important things like just conscious or not conscious, able to interact or not, are super important, but it's not enough. We really have to get beyond it to know, are they going to be independent? Are they going to be, quote, who they were before, right? I think that's the hardest thing to say. And then even harder than that too is, we know this concept of the disability paradox where People who do not have a disability, if they're asked to anticipate, what quality of life would be like with a disability, they rate it as low. But when you ask people who actually have a disability about their quality of life, it's not rated as low. So it just sets up a very challenging decision-making framework for thinking about advanced care decisions and care planning and withdrawal of life-sustaining therapy.
I am always amazed. I remember talking to a patient years ago, and she was so offended that MRS3, which was her, she has a wheelchair. She's like, you lumped me with people who are dead in terms of outcome. And she was absolutely right. She had this great life. She just needed assistance. And I think there's a lot of bias and discrimination that goes into those decisions that is kind of stacked in the literature and the way that we think about outcome and hard to disentangle sometimes. Although I think humility probably goes a long way.
Yeah, completely agree. I think we still have to dichotomize. But exactly like you said, we have to acknowledge the limits of that. The post-ICECAP study is getting started with Sachin Agarwal at Columbia University, who's another one of our neuro ICU colleagues, really going to be looking at these long-term outcomes for cardiac arrest survivors, doing neurocognitive testing, neuropsych. I think it's super important that we get more granular data. And then we need to engage our patients, do patient-centered care, and really figure out what are meaningful outcomes of interest to them in this population, which we just as a field have not done a good job of.
Well, it's all very exciting. I think even in my career so far, it's been pretty amazing to see the changes in the way we care for patients and the way we talk about care for patients. As we wrap up our conversation today, I think given the ongoing problem with prognostic uncertainty after cardiac arrest, we all struggle a little with the right words to how to convey that prognosis to families. I've been doing this a lot longer than I used to, and I still think it's hard to find the exact way to communicate. And obviously that's also nuanced depending on individual family members. How do you go about conveying prognosis in your clinical practice as someone who has expertise and research in this? And do you ever offer numerical estimates? How do you generally kind of structure those prognostic discussions?
Yeah, I will also say that I try to be very humble in this and think that, again, with experience and age and wisdom has also made me very cautious about how I do this. And I think there's also a lot of very interesting literature out there about the words we use as physicians and how we give prognostic estimates and what we think that means and what the patients and the surrogates are actually taking away from it. So I don't have a perfect answer, but I think in general, it takes multiple conversations with similar messaging. I always try to do it in a setting where it's non-threatening and make sure that people know up front that I don't have an agenda here. I think a lot of times families and surrogates walk into it thinking, oh, the doctors want me to do X or Y. So I think just making sure that we set a level communication field where we're allies in the decision making. And then exactly like you said, being very clear that there's a lot of uncertainty around these estimates and prognosis. I tend to say things I can tell you with certainty. I can tell you with certainty they will need a trach, they will need a PEG for the short term, foreseeable weeks to months. They will be in a facility. And then I try to acknowledge the longer term recovery and what is uncertain. I never give numbers only because I think it's arbitrary. And if I based it on literature, as I said earlier, that literature would be flawed. So I don't give numbers. So I don't have a perfect answer, but I think we'll continue to evolve together.
It's all right. I feel like never perfect answers. I'm at a point where when I take board exams, I'm almost like calmed because there is actually a right answer, which is not the experience I have in any other part of my clinical career.
Exactly. You think you know everything when you finish training, and then we reach mid-career and we don't know as much as we thought we did.
That's what keeps it interesting. Well, thank you so much to Dr. Karen Hirsch for taking the time to talk with us today and for sharing her expertise and enthusiasm for this important topic.
Thank you so much for having me.
That was Dr. Karen Hirsch of Stanford, interviewed by Dr. Sara Stern-Nezer of UC Irvine. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Michelle Johansson. I'm Adeline Goss, podcast host and executive producer. Our program was produced today by Sara Stern-Nezer, Caitlin White, and me, with help from Jen Hurley. You can listen to past episodes of the show, subscribe to us so you never miss an episode, and access all of the ANA's educational programs on the Education tab at myana.org. That's it for ANA Investigates. See you next month.